Hello everybody, recording live from somewhere. It is Zach Couples with episode 1, 2, 3, 4 of the Movement Debrief, where today we are going to discuss 3 cases since I'm back in the clinic in lovely Arizona, and we're going to talk about someone with an ACL repair and why I emphasize hamstrings over quads. We'll talk about why the hips lie sometimes. That's a patient who had knee pain, so we'll talk about that. And then we will talk about giving the patient what they need versus what you feel they need. So that's what's in store. I hope it's not too windy, and I hope you guys can hear me okay. It's beautiful outside. That's why I got this cutoff on, and if you don't like it, as the old meme says, deal with it. A little bit of housekeeping before we get going. Did you guys check out my blog? I'm starting to put them out on Mondays now. It's better for my schedule, and I'll be able to put out better content for you guys by doing it then. But I wrote about continuing education, everything you need to know about doing well at it, because there were many times I did not do well at it. So I want you guys to be successful. So, yeah, go check that out, zachcouples.com. That's really all I have update-wise. So let's get into it. Okay, case 1. So I saw this girl. She had an ACL repair. Interesting repair that she had. It was a combo graft where she used a hamstring tendon and a cadaver tendon. First time I've ever seen that, first time I've ever heard of it. So, yeah, something different. I'm not the biggest fan of hamstring grafts, and I'll tell you why that is. It goes along with this whole discussion. But the first activity I gave her, believe it or not, did not involve the quads. And she, just to talk a little bit about how she was from a presenting standpoint, she had a limitation in extension, very typical after this type of surgery. She was about 8 degrees of hyperextension on the other side, immensely flexible. She was probably at about 2, 3 on the affected side, which, I'm trying to think, it was her left leg. Yes, it was her left leg. And another thing of note was her hamstring flexibility, despite having this cut in the tendon, was remarkable. Like, I reached 90, and I didn't want to keep going because she had no resistance whatsoever. So, commonly, when you see someone who has a limitation in extension, you would think, hey, let's stretch into extension and let's activate the quads. I think that is a dated concept. Here's why I think it's a dated concept. You have to consider the function of the hamstrings. So what does the hamstring do? Well, we know that it flexes the knee, we know that it extends the hip, and depending on if you're the semis or you're the biceps femoris, it also can rotate the femur, right? Another thing that it does that's not often considered is it checks anterior translation, so it limits that. So if I have a female who has a limitation in knee extension but an excessive straight leg raise, consider that the hamstring crosses both of those joints. So could it be, for 2 reasons, that limitation in extension is protective? And I would argue that arthrogenic inhibition of the quadriceps is also protective. Because if I have an excessive amount of mobility in my straight leg raise, it would make sense to limit motion at the knee joint so 2 things don't happen. That happening, right? Anterior tibial translation, which is what your ACL checks, and I don't overstretch the hamstrings. So what I did instead of doing quad sets or stretching into extension was I gave her an activity that emphasized hamstring activation. Now, when it's my phone is hot. That's not good. Hang on, technical difficulties, people. All right. Sorry about that. What is going on? Man. Okay. Sorry about that, people. Had some technical difficulties. The weather is fighting me. So, we were talking about hamstring activity, right? So, checks anterior translation of the ACL. And so I gave her a hamstring activity. Now, the fact that she had a graft that was hamstring, you obviously can't flex the knee, right? That's one of the contraindications. So what I gave her, you'll be able to see this. So there is some benefit to the technical difficulties. Was this? It's called long seated press down with abdominals. So you would have dumbbells, but weight here, weight through the heels. I'm going to tuck the hips so that posterior pelvic tilt is going to engage the hamstrings proximally, and you're going to lift up. Okay, and I feel my hamstrings working because I'm digging in my heels. Pull my shoulders back. 5 breaths. So we did a few rounds of that. She was shaken, and guess what? We had full knee extension afterwards, which was pretty remarkable, at least passively. Now, actively, we still had some problems. There's still arthrogenic inhibition going on. We still have a crazy amount of hamstring flexibility or straight leg raise that we have to deal with. So, but that's like a good starting point for us. That's why I emphasize the hamstrings before the quads, because if we can restore knee extension and we put the pelvis and increase hamstring enough so that it's in a good position, that's going to allow the quad to contract a little bit more effectively because we're not going to get excessive anterior translation. Now, what I'm going to try to do with her next time, because I do want to mitigate any atrophy that occurs at the quad, is we will do a BFR plus E-stim combo. There's I'll put this up when I put this on my blog, or I'll put a link to the protocol for that. But combining those two things has done wonders for maintaining quadriceps muscle bulk, as we know that that's a risk factor for problems down the line if you don't restore that. So I challenge you people, next time you have someone with an ACL repair or basically any knee surgery, make sure you're checking straight leg raise. And if that's excessive, or even if it's limited for various reasons, go after the hamstring first. I am telling you, you guys will notice a big difference in restoring the extension. So that was case 1. Case 2, this time I'm going to talk about the hips lying. So I had a guy, he is a server, and he was experiencing bilateral knee pain for being on his feet all day. And, it was kind of diffuse, wasn't really like anything crazy going on at the joint. And he himself stated that he was a very stiff guy. He mentioned that when he was younger in PE class, when he went to go touch his toes, his instructor would just try to push him down so he could get there. Don't do that. That's not an effective strategy. And so, I went and just checked this guy out, range of motion-wise, all that. He had some limitations in hip adduction and hip extension. But interestingly enough, he had a lot of hip internal rotation. He had about 40 degrees both directions. He was more limited in external. And so, treatment-wise, given that he has a limitation in hip extension, limitation in straight leg raise, can't touch his toes, we went with a couple sagittal plane activities. I gave him a 90-90 hip lift, which you're lying on your back, feet in the air, digging your heels down, kicking in the hamstrings. First, we were able to get full extension with that. And the second thing I gave him was an all-four breathing position to emphasize the abdominals. And we didn't get much change in hip adduction. Now, here's why the hips lie. You would think that if I have someone who's limited in, or not limited in hip internal rotation, that you oftentimes don't have to stretch the posterior hip. But in this case, that was incredibly false. So I decided that, we were getting a little bit of symptom change, but nothing wild and crazy. He still couldn't touch his toes. So I decided to just give him a posterior glide into the back of the hip on both sides, see what happens. His hip adduction range of motion after we did that was normalized. Pretty remarkable, because considering how hypomobile this guy was. And he got up and damn near touched his toes, was able to squat to parallel, which he was not even close to that without any pain, and much, much less discomfort in a lunge position. So, when you are looking at the hip joint, be careful about how you interpret hip rotation. I think the most important test that we can look at from a hip perspective and pelvis perspective is an Ober's test, or if you're into PRI, adduction drop. That to me is a much more valuable marker, and you want to be able to get that cleaned up first before you go and attack rotation in either direction. And so, guys, if you can extend the hip all the way in your Ober's test, but you're still having trouble adducting, and it doesn't feel like a hard stop, like it's kind of soft, don't be afraid to stretch the posterior hip. Don't be afraid to get these people squatting. That will be immensely helpful for improving hip motion. So that was case 2. Case 3. This one, man, this is one that still kind of has my wheels turning a bit, because I just don't know. And let me give you a little bit of backstory with this girl. So she was seeing a therapist prior, and is doing well. Right, she was there for back pain. Her back went out. Where it went, who knows? But she was there for back pain. Did some treatment, a couple sessions with this guy, and got better. Back pain was okay. She came to me saying that she was getting a little bit of knee pain with squatting or picking things up, and just had general fear of doing any type of bending over or squatting to pick things up. Wanted to make sure everything was picked up with efficient body mechanics, so on and so forth. And so she came to me because she wanted to work on that. And of course, I went and performed an examination, and she was a stiff girl, was unable to touch her toes, couldn't adduct her hips, all of these things. And she's kind of a girl who has a hard time sensing things. And so what I did was, what I would normally do was I gave her some activities to try to improve mobility. We got a little bit of success, but nothing wild and crazy. And then we spent the remainder of the time working on picking stuff up off the ground. And obviously a little bit of education too, because we want to make sure that she does not go into fear avoidance mode, even worse than she already is. And I guess where I'm struggling with this case is the dichotomy between when we make selections of interventions for our patients. The question I ask is, am I doing this for them, or am I doing this for me? And I fall into that trap quite a bit, because I've done all this education, obviously, and I've been well down to the PRI rabbit hole, and you see things that that, oh man, I'd love to address this because I think it could improve them. And I wonder if in this case, doing some of those interventions to improve her mobility was that case. Like, was I trying to get her neutral from a PRI lens, or increase her flexibility so it made me feel good? Or was I doing it to make her feel good? And I don't know what the answer is there. Because she came to me to get help with picking stuff up off the ground. And after reflecting, after we did this, it's like, man, although I spent a decent amount of time teaching her that, like, we could have spent a lot more time working on that. And I wonder if, had I started with that first, and seeing if I could coach picking up, and not just picking up, like a deadlift position, but in multiple positions, if that would have been a more impactful treatment for this woman than if I had not done that. And I don't know what the right answer is for that. This kind of goes back to my concept, if you check out my blog, with start at the end. And I think this, and basically what that talks about is try to keep that individual as close to the activity that they're intending to do as possible. And I think that was a case where I neglected that. And, a part of me wonders, how often do we fall into that trap where we go into these very esoteric and in-depth rehabilitation rabbit holes and while we do that, losing the patient's goal in mind. And I think that we probably do that more often than not, and I think I did that with this woman. So how am I going to rectify this? We're going to get her squatting. We're going to get her deadlifting. We're going to start there first. We're going to start at the end, and we're going to get her comfortable picking stuff up in multiple positions. And if we don't meet our needs there, then I think we need to go a step lower. And maybe that's addressing basic instinctuals. Maybe that's addressing mobility. And maybe that's enough for this woman. And I think we'll call that it for today. So I want to thank everyone for listening. Be sure to check out zachcouples.com and check out my most recent blog post on continuing education. You can follow me on Facebook, which some of you people already are, at /zcouples. I'm at Twitter as well, /zcouples. And I'm also on the good old Instagram at my name, Zach, Z-A-C, Couples. If you go to my website, please sign up to my newsletter. You'll be privy to all the new things that I put out before anyone else hears about it. So, thank you for your time, and peace out. Maybe.